Russ Bowler is a pulmonologist at National Jewish who is one of the co-directors of the COPD program and a principal investigator in the COPD gene study and part of the Alpha-1 team at National Jewish, who has taken the opportunity of the state of Colorado's legalizing marijuana to help evaluate both what's happening in marijuana sales, usage, things like that, and also help in the evaluation process of whether there are components of marijuana that might have beneficial effects in humans. And I went to a conference he put on several months ago where there was a litany of investigators who were looking at neurologic issues and the use of cannabinoids, the kinds of chemicals that are in marijuana. Obviously, neurologists are interested in seizure prevention and treatment with cannabinoids, and of course looking at various pulmonary conditions and things like that. So there's also the issue of e-cigarettes, which is a big unknown, especially for pulmonologists. Have we benefited patients, or have we benefited smokers in some way with the proliferation of e-cigarettes in the population? So I'm going to try to recreate some of the things that Russ talked about, because I know there's great interest in these things. But he started out with this slide, which talks about the use of e-cigarettes in the last 30 days. In other words, he asked people, he didn't, but people were asked, in the last 30 days, have you used an e-cigarette? And these people were divided into those in middle school, high school, and adults. And the most disturbing aspect of this is, of course, the very high number and growing number of kids in high school who are using e-cigarettes. But adults are also using more e-cigarettes over the years, and so are middle school kids. And so then the question is that a horrible thing, or is that a good thing? Are we switching people over from cigarettes to e-cigarettes? And are e-cigarettes somehow more innately healthy than traditional smoked cigarettes? Or is this simply changing the delivery system and maybe even attracting younger kids and more kids into becoming addicted to nicotine? So this was his disclosures. That's the Colorado Department of Public Health that's afforded him, as well as the National Institutes of Health. There have been lots of recent publications on the prevalence of e-cigarette smoking, and he used these things to come up with some of the data that he showed us. This is what an e-cigarette looks like, in case you're unfamiliar. There's a battery. There's a coil that heats a solution in the vaporizing chamber. There is the appearance of smoke, which is actually vapor from some of the chemicals that are boiled away, if you will, in the e-cigarette. I think he said it was primarily glycerol and glycerol derivatives that make the vapor that you can see as smoke when they're used. And there's even a little LED indicator at the end for people who like to think that their cigarette is lit. And as you can see, a lot of these are being made to look like cigarettes and have the same form factor and stuff as cigarettes, so that people are either comfortable going from cigarettes to vaping, or the sinister view of it is make people comfortable using something so that when they eventually go on to cigarette smoking, it'll be familiar to them. So e-cigarettes for use for smoking cessation. There have been studies that have tried to evaluate whether people who use e-cigarettes are more likely to quit smoking, even if they continue to vape or use e-cigarettes. There are studies about the toxicity of e-cigarettes, and then there's studies about young smokers being enticed into using e-cigarettes. So The studies have shown that, that e-cigarettes are modestly effective for smoking cessation at 6 months. Russ stressed that you have to look at least 6 months because almost all smoking cessation programs have early success and then recidivism. And if by looking at least 6 months, you're much more likely to find good results. E-cigarette use is associated with higher biochemically verified continuous tobacco smoking abstinence at 6 months by looking at inhaled breath carbon monoxide, which is a way of evaluating whether someone is still smoking cigarettes. So they gave a 1 week pre-quitting and then 12 weeks of therapy. It was done in New Zealand. They had 3 groups that were randomized either to receive nicotine-containing e-cigarettes for 12 weeks, nicotine patches for 12 weeks, or placebo e-cigarettes that didn't have any nicotine in them. And the primary outcome was abstinence from smoking at 6 months. This is just a complex diagram showing that they had about 289 people in the group that got e-cigarettes, 295 in the group randomized to receive the patch, and 73 patients randomized to receive placebo because they randomized in a 4:1 ratio on those 3 groups. And what did they find? That there was no difference at 6 months in smoking cessation rates in any of these groups. They all had, by the end of 6 months, about 20% of the patients had continued to be smoke-free. There was some differences. You can see differences, at 3 months and at a month and a half, that suggested that perhaps the e-cigarette e-cigarette had a little better quit rate early on, but by the time you look at 6 months, there was absolutely no difference between them. And that the other thing about this, these are all people who wanted to quit cigarettes. So it was a motivated group, and it didn't matter what you did, as long as you paid attention to them, gave them something to do to help them smoke, 1 out of 5 would stay smoke-free, whichever technique you used. And they also looked at for people who used an e-cigarette and also smoked cigarettes, how many cigarettes did they smoke while they were using an e-cigarette? And so they compared the patches with those that got nicotine cigarettes, how many cigarettes did they additionally smoke? And you can see that at 1 month, the number of additional cigarettes smoked was improved and started to climb up by 6 months. But Russ pointed out that the difference between here and here is a difference of about 2 cigarettes a day. And so even though it was statistically significantly different, it was unlikely to be clinically different or a different risk just because they cut down on from whatever it is, 40 cigarettes a day to 38 cigarettes a day. And so he goes through all of these reasons that this was maybe not the best study. And then talks about the fact that there was no reduction in tobacco cigarette use at 12 months. So here's a different study. They randomized patients to receive e-cigarettes with moderate amount of nicotine for 12 weeks. The second group got a moderate amount of nicotine for 6 weeks and then a lower dose nicotine e-cigarette for 6 weeks, and a group that got nicotine-free e-cigarettes, so the placebo group. And they evaluated those over 12 weeks, and then they looked for smoking cessation at the end of 52 weeks. And what did they find? Well, first, these had equal number of patients in each group, 65, 63, 55, almost equal. And what did they find? They found that there was a dramatic reduction in the number of cigarettes per day at 2 weeks, and then 10 weeks, and at 52 weeks, there was no difference between the groups in the number of people who remained with lower doses of cigarettes. It looks almost exactly like the last curve I showed you of the reduction in the number of cigarettes. And no less reduction in tobacco cigarette use with nicotine e-cigarettes versus the placebo. No significant difference in the quit rates in those groups. The placebo did a little worse than the 2 e-cigarettes, but still not really. First of all, these quit rates are terrible. 10% of the entire group quit with the e-cigarettes of various kinds, and 5% with placebo, but not statistically different. Again, a list of things, a list of problems with that study. If we look at the idea that e-cigarettes have lower toxic chemical levels than smoked cigarettes, is that true? Well, what do we find? We find that if we look at the usual carcinogens in conventional cigarettes, every one of those is in electric cigarettes, in the e-cigarettes, although they are, on average, at lower doses than regular cigarettes. So that is a positive, but they still have those carcinogens in them. And this is the ratio of e-cigarettes to conventional cigarettes in terms of the amount of each of these carcinogens that are there. I think we can skip this. So let's move to marijuana. So marijuana comes from the cannabis plant, related to the hemp plant. It has THC, tetrahydrocannabinol, the active ingredient that people are looking for in general in marijuana, throughout it, but the vast majority of the cannabinoid THC is in the buds of these plants. And if you happen to wander into a marijuana store here in Colorado by mistake, you'll notice that that the material they sell is mostly flowers and buds, and that's the desirable part. You can also make very high potency forms of THC from the material in plants. And the horticulturists have been very good at increasing the concentrations of THC in the various marijuana plants. They make an oil, a wax, and something called shatter, and all of these have about 90% THC. And you use those by putting them in the same kind of e-cigarette apparatus that you would use for tobacco, for nicotine delivery. And there's also dabbing, in which you heat these products and inhale the vapor, as Russ said, very much like freebasing cocaine, and very high potency methods of delivery. And there's also edibles. And one big problem that occurred in Colorado when these became available is that most of these edibles were designed to look like gummy bears, Pop-Tarts instead of Pop-Tarts, and all kinds of gummy things. And there was enough childhood, children finding these things, thinking they're candy and swallowing it, coming to the emergency room, that the Colorado actually has enacted a law relatively recently that February 1st, 2015, which mandated childproof packaging, mandated that there were no easy open devices, had a Poison Prevention Act compliance, and they could not appeal to children. And so currently, it limits the amount of THC in these things and tries to make them less appealing to children. There are cannabinoid receptors are naturally occurring in the body. They are in the brain and also in the GI tract. And the common ingredient that most people know about, tetrahydrocannabinol, or THC, which is the thing that makes you high from marijuana, is one of many cannabinoids that are present in marijuana plant, and many people have concentrated on CBD, which is cannabidiol, and is the thing in the movie that supposedly stopped children's epilepsy and things like that. And this does not have the same psychological effects that THC does, and is felt to have some beneficial effects. And you can buy products that are highly enriched for CBD, and they're being studied for medical uses as well. Again, this is how these things are metabolized. The Retail Marijuana Amendment 64 was passed in November 6, 2012, and marijuana was, after it passed, was legalized in January 1st, 2014, the first state in the country to legalize marijuana. We also have had medical marijuana for many years, and in many states around the country there's legalized marijuana. According to the data that Russ cited, 304,858 medical marijuana cards have been approved in Colorado, of which about a third of them are still active. The indications that are accepted for a prescription of marijuana include this list, and you can see the vast majority are using it with a diagnosis of severe pain. This is what it looks like federally. States that have decriminalized marijuana have medical marijuana as in its CBD form, allow medical marijuana and THC, have decriminalized medical marijuana, and have totally legalized marijuana. You can see Alaska, Colorado, Oregon, and Washington so far. And those states are expected to grow as more experience is gained with marijuana legalization. And some of the data that I'm about to show you. So the first question that probably is in the minds of many people is, has legalization of marijuana in Colorado changed marijuana usage? And so I'll do what Russ didn't do. How many of you think that the marijuana usage has changed? For instance, gone up since the legalization of marijuana? Reasonable assumption. That's wrong. So along the bottom here, we have the years. Remember that the marijuana law was actually changed over here. And this is comparing US usage with Colorado usage. Colorado usage in green, US usage, asking two different questions. Have you ever used marijuana? And have you used marijuana, I think it was in the last 30 days, is that right? And this is among high school students. And you can see that there's pretty much a flat line for the answer to those questions, and no step up since the legalization of marijuana in Colorado. Marijuana use in high school and middle school. Here's pretty much the same thing. High school ever usage, high school usage in the last 30 days. And if you add middle school ever usage and middle school current usage, and an age group which we didn't think was important to ask in before 2011, you can see that it's stable but significant amount of use in middle school. Marijuana use in high school compared to alcohol and tobacco use. Now, as Russ pointed out, in Colorado, it's illegal to buy alcohol if you're under 21. It's illegal to buy retail marijuana if you're under 21. And it's illegal to buy cigarettes if you're under 21. But this is the rate of use of alcohol, marijuana, and tobacco in a group of high school students who are under 21. And you can see alcohol is still the favorite, and tobacco use is declining slightly, and marijuana lies halfway in between alcohol use and tobacco use. This doesn't tell us whether people are using all three, I guess. Frequent marijuana use among high school students. The frequency of marijuana use among high school students that reported current marijuana usage. How many times in the last 30 days? You know, there's a range. And it really hasn't changed over the years since marijuana was legalized over here. So implications for health. There's no ICD-9 or 10 coding for marijuana medical use. Lung health, sleep. I think he skipped over it. Well, this is one of the interesting things where there was a signal. the number of marijuana exposure calls to the Rocky Mountain Poison Control Center. And you can see this is divided into by age group. And you can see that since the approval of retail marijuana in Colorado, the calls to the Rocky Mountain Poison Center have gone up significantly, doubled, if you will, and in almost all age groups. One possibility is people feel okay calling about issues with marijuana overdose or whatever, whereas before, since it was illegal, they might have been hesitant to call. What about the lung findings? What's the effect of marijuana on the lungs? Well, there's very little evidence, but the evidence that we do have says, number one, we know it contains the same carcinogens in marijuana and tobacco smoke, although in different actually not in different concentrations. In marijuana, it's pretty much the same concentrations. And chronic use of marijuana appears to increase airflow obstruction. You get macrophage deposits compared to tobacco. And there's insufficient evidence to say whether emphysema and COPD is increased. Chronic bronchitis, cough, and wheeze. The level of evidence in marijuana versus cigarette smoke, really not there. We just don't know a lot about this, but we do have some information. Remember I showed you the fact that in e-cigarettes there's the same carcinogens but at different concentrations, lower concentrations in e-cigarettes. Not the case for a marijuana cigarette that's smoked. Obviously there's differences. Marijuana contains THC and cannabinoids that tobacco doesn't have. Cigarette smoke has nicotine that marijuana doesn't have. But in terms of various carcinogens, naphthalene and these various benzo compounds and phenols and particulates, they both have them, and they both have them in roughly the same amount. Also, you get the same changes in the airways. If you look at the airway epithelium under the microscope, you get thickened. This is normal. You get thickened epithelium and proliferating epithelial cells as with marijuana and with cigarette smoke. If you try to look at if this abnormal histology leads to lung cancer, there's absolutely no evidence in the studies that have been published so far that there's an increased risk of lung cancer in people who smoke marijuana. Good news, I guess. But there is an increased incidence of cough, sputum, wheeze, and acute bronchitis in marijuana smokers, that's the blue, in tobacco smokers, that's the yellow, and in people who smoke both marijuana and tobacco compared to people who are non-smokers. And the amount of those, of cough, sputum, wheeze, and acute bronchitis appears to be similar between cigarette smokers and tobacco smokers. Got me. I think, does marijuana smoke lead to COPD? Well, in studies that have been done so far, the bottom line is that there is no evidence yet that chronic marijuana smoke leads to significant lung disease. There are some studies that have showed decreases in FEV1 FVC ratio. There are some studies that have shown increases in FEV1 FVC ratios. So the jury's still out. And the association with emphysema is not felt to be there yet either. As far as the studies that have been done so far, there's no convincing evidence that chronic marijuana smokers develop emphysema. So conclusion, electronic cigarettes are rapidly increasing use in every age group. No convincing evidence that e-cigarettes lead to improved quit rates. They may reduce tobacco cigarette consumption, but probably not significantly. They are associated with increased and prolonged e-cigarette use. Once you're on e-cigarettes, you're addicted to nicotine from those e-cigarettes. E-cigarette vapors contain similar toxins to tobacco smoke, but at lower concentrations. A bit of good news there. Marijuana smoke has toxins similar to tobacco smoke and at the same quantities as tobacco smoke, with bronchial epithelial pre-malignant changes, but has not been convincingly shown to lead to lung cancer. Marijuana smokers have more cough, sputum, wheezing, but long-term studies showing higher rates of emphysema or COPD are lacking. Although marijuana may result in acute bronchodilation, there's no evidence that it's an effective asthma treatment. That's something we didn't talk about. And so that's the end of Russ Bowler's presentation. And I'm happy to have you ask him any questions you would like. Yes, sir. The question was, there's controversy about the use of various pain anti-inflammatory and non-steroidal anti-inflammatory agents, Tylenol. It's an area of ongoing controversy with different physicians having different beliefs from different studies, whether the risk of liver disease and Tylenol taken at the correct dose is significantly more in Alpha-1 than the general population, whether the risk of non-steroidal anti-inflammatory agents like Aleve and ibuprofen and stuff might be more damaging in Alpha-1 patients. Some animal studies have suggested that, but it's not been documented in humans. But given all of that, if you want to do something other than those controversial pain reliefs, the question was, does CBD have as one of its medicinal properties pain relief? And the basic answer is we don't know yet. There's certainly claims of that. Some people that actually take medical marijuana for pain, there is some limited evidence that CBD is the active ingredient that does help those patients rather than the THC. But your knowledge of it is as good as mine, and probably Russ wouldn't have any additional things that he could say regarding that, because I know that's one of the things that's being looked at by the studies that are now starting at University of Colorado, National Jewish, other places. We were really restricted from doing clinical trials with marijuana and its products while marijuana was illegal in the state. That's one of the things that legalization has helped with, is getting some actual objective evidence about whether these things are beneficial. But unfortunately, the results aren't in yet. Yeah, I mean, the best information that I have and that I tell my patients is that Tylenol taken at recommended doses is probably no more dangerous to an Alpha-1 patient than to any patient, unless they already have liver disease. There are certainly cases of people who've had liver injury, not with Alpha-1, from approved doses of Tylenol, but they're few and far between, and every drug has its toxicities. That's within the recommended doses. I mean, if you're concerned then about doing that, one of the things that can be done is to check your liver function, while you're using it. Other questions? There's a stand right outside the door. Sell you your samples when you leave. Thank you very much.